if I can figure it out, you too can figure it out. With simple motive, let's begin our discussion on SLE, systemic lupus erythematosus, right? The earlier lecture that we had was autoimmune disease. Now we'll be discussing on the topic of SLE. What is this? This is simply an example of what? Autoimmune disease or autoimmune disorder. Now, as we can see, there is systemic in this name, so it means that in this disease, in this autoimmune disease, there will be involvement of what? Multi-system disorder. Okay, multi-system disorder. Okay, talking about multi-system disorder, right? Obviously, multi-system disorder means several organs, several system of body will get involved, right? Okay, now talking about several system and several organ of body, I would like to take you toward the blood and organ. Okay, what will happen is blood and organs. What will happen here is when we are having autoantibody in this patient, these autoantibody are going to cause damage in blood cells and also in organs, right? Now talking about blood cells, these autoantibodies are going to damage blood cells, right? And which will eventually cause autoimmune hemolytic anemia, similarly autoimmune leukopenia, autoimmune thrombocytopenia, right? If autoantibodies are produced against RBC, then obviously autoimmune hemolytic anemia, similarly to WBC, leukopenia, and to platelets, thrombocytopenia. So since this is antibody mediated reaction, so here in the case of blood, what we will mention is this is type 2 hypersensitivity reaction, right? Why? Because it is what? Autoantibody mediated. Now talking about organ, what happens in organ is, in organ we get the formation of antigen antibody complexes. What we get is, we get the formation of antigen antibody complexes. Now talking about antigen antibody complexes, if we recall our discussion in hypersensitivity reaction, then we'll find antigen antibody complexes are found in what? Type 3 hypersensitivity reaction, right? Okay, now this was all about what? This was all about a brief discussion, a brief explanation about systemic lupus erythematosus. Now let us talk about what causes systemic lupus erythematosus, right? It's etiological and pathological factors, right? Now here we have the diagram from 10th editions Robbins, right, talking about the pathogenesis of systemic lupus erythematosus. Now talking about the systemic lupus erythematosus, right, here we have got that there are several causes for causing SLEs, such as we have got here susceptibility genes, right? There are genes that are going to play a role in causing these things, right? What these genes will do is they will enhance the production of B and T cells, the self-reacting B and T cells, right? Okay. Similarly, as gene was contributing, there are also external triggers, right, such as UV radiation. What this UV radiation will do is they will lyse the cell, right? They will break down cell and they will produce a large amount of apoptotic bodies through the process of apoptosis. Now here what happens is there will be a large number of nuclear antigens, right? A large number of nuclear antigen burden will be coming into circulation, right? And these antigens, nuclear antigens, now they are going to be acted by what? The B and T specific for self nuclear antigens for them, right? And when these antibody will start binding with these antigens, right? These are the antigens, these are the antibodies specific for these antigens, and when these two combine, and there will be the formation of what? Antinuclear antibody antigen antibody complexes, right? Okay, simple, it is simple. That means there will be the formation of what? Antigen antibody complexes. You can see these are the antibodies and you can see these are what? These are the antigens, right? Okay, there comes the formation of antigen antibody complexes. Now what will happen is these antigen antibody complexes, look, you can see here what will happen here is these are endocytosed, right? By whom? By B cells. Okay, endocytosis of antigen antibody complexes and toll like receptor engagement is seen by nuclear antigen. That means these will be taken up by these B cells, right? Dendritic cells. And what will happen is, since these were what? These were what? Nuclear antigens, right? So there will be the involvement of toll like receptors. You can see here. Now these toll like receptors will cause stimulation of B cell and D cells. Now these toll like receptor, you can see these are the toll like receptor. Now this will cause what? These will cause stimulation of B cell and dendritic cells. Okay, stimulation for what? Stimulation of B and T cells by, okay, now stimulation will take place, and this stimulation will cause a large number of production of plasma cells. You can see here plasma cells, and these plasma cell will eventually produce a large number of self-reacting what? Self-reacting antibodies. Now since there is a large number of self-reacting antibodies, obviously it will enhance the systemic lupus erythematosus, which is autoimmune disorder, right? Okay, now this was a little detail about pathogenesis of systemic lupus erythematosus. Okay, let us read here the model for pathogenesis of systemic lupus erythematosus, right? In this hypothetical model, susceptibility gene interferes with the maintenance of self-tolerance. Okay, right, with the maintenance of self-tolerance, and external trigger lead to persistence of nuclear antigen. External trigger, what it is causing is, it is causing release of what? Nuclear antigen. And what this susceptible gene is doing is, this susceptible gene, it is interfering with self-tolerance, and as self-tolerance is interfered or destructed, obviously there will be a large chances for autoimmune disorders. Okay, now the result is antibody response against self-nuclear antigen. Obviously, that we have said, the antibody, right? These are the antibody, they will react with antigens, right? Nuclear antigens, which is amplified by the action of nucleic acid on dendritic cell, DCs and BCs, and production of type 1 interferon. Okay, now here what will happen is, there will be a production of type 1 interferon, and this type 1 interferon will enhance, right? This will enhance and will help in activation of what? Phagocytic self-reactive cells. So this was all about what? This was all about the pathogenesis of systemic lupus erythematosus. Talking about, okay, we were going to talk about the etiology, right? Talking about the etiology, or we can say, talking about the etiology, we have already mentioned gene susceptibility, external triggers. Now let us focus toward the risk factor, right? What we'll be talking about? Risk factors. Talking about risk factor, I would like to mention, okay, the risk factor, they can be such as what? Genetic factor, right? What I said is, okay, they can be genetic factors. Now talking about genetic, okay, we'll mention it earlier, we'll discuss that in detail later. And another is immunological factors. What I said is immunological factors. And another factor that we need to discuss is environmental factor, that we have already discussed, the environmental, sunlight, UV rays, mental factor. Okay, now talking about the genetic factors, there are what? Okay, talking about genetic factor, we have got C proteins, complement proteins. What I said is complement proteins. Okay, now when there will be deficiency in, okay, because of genetic factor, when there will be deficiency in complement proteins, right, such as C1, C2, C3, then due to the deficiency of complement protein, they won't be able to completely remove what? The causative agents for causing autoimmune disorders, right? What these complement protein deficiency will do is they will cause less removal of immune system, they will cause the less effective removal of the antigens, self-reactive antigens, right, to prevent autoimmune disease. And that is why it is the important risk factor, right, is risk factor. Now talking about another cause for genetic factor, we have got we have got HLA-DQ gene. What I said is we have got HLA-DQ gene. Now what is this DQ gene? I have already said you earlier, this HLA, right, human leukocytes antigens are also called MHC. MHC are also called HLA genes, right, major histocompatibility complex, right, and these are also associated with the risk factor for our SLE. Talking about the environmental factor, in environmental factor we have got we have got is sunlight, UV rays, right. We have got UV rays. What they do is they cause lysis of cell, and because of which large number of antinuclear antigen will come into circulation, and these antinuclear antigen will promote or will enhance the production of large number of self-reactive T cells and B cells. Now talking about environmental factor, we have got sex, right, sex. And talking about sex, we have already discussed in autoimmune disorder that female are more susceptible to these diseases than male. Why? Because their female contains progesterone and estrogens hormones, right. Okay, now talking about immunological factor, right, immunological factor. Talking about immunological factor, we have got we have got lymphocytes, excessive amount of lymphocytes activations, right, lymphocytes activation, right, T cell and B cells. Now okay, now I have mentioned in this way, but I would like to just tell in a list wise. Okay, talking about the risk factor, we have said that female are more susceptible for SLEs than male, right, because of hormone estrogen and progesterone. And another thing is the female of reproductive age are more susceptible, right, more susceptible, because since reproductive age group contains this estrogen and progesterone hormone. And another we have discussed is HLA-DQ, right. DQ is associated with the risk factor of SLEs. Similarly, UV rays, we mentioned about UV rays. And talking about after UV rays, we are going to mention drugs, and these drugs are also the under of environmental factor. Now talking about drug, we have already talked that there are various drugs, right. Through acronym we have learned that SHIP, right, sulfonamide, hydralazine, and there are many other several drugs that are enhancing the risk factor for these SLEs. Now talking about, and another thing that we mentioned is complement proteins, right. When there will be reduction in complement proteins, then they can't remove the causative agent for SLEs, because of which there will be a high risk for causing of the systemic lupus erythematosus. Now talking about these things, now we will focus on criteria, right. We will be talking about criteria. That means how we can say that the person is suffering from systemic lupus erythematosus. Talking about the criteria, right, we have divided criteria into clinical criteria and immunological criteria. This is also a chart from Robbins 10th edition. And talking about critical criteria, we have got acute cutaneous lupus. What we got is we got acute cutaneous lupus. What happens here is okay, this acute cutaneous lupus, it is in form of photosensitivity skin rash. What I said is photosensitivity skin rash. Talking about skin rash, the rash which is present here, it is the malar rash. Okay, now what is this malar rash? This malar rash can be understood from another name, and the another name is butterfly rash, in which there is rash that will present from this breeze between the nose, right. It will spread in such a way, right, they will reach toward the malar region or the cheek region, and that is what the malar rash is, right. Now another thing is the chronic cutaneous lupus. Okay, there is chronic cutaneous lupus. Now what is this chronic cutaneous lupus? If we were talking, before we talked about malar rash in acute cutaneous lupus, here in chronic cutaneous lupus we will be finding what? Discoid rash. And about these things we will be learning in detail after some time. Discoid rash. Okay, this was the in what? Chronic cutaneous lupus. Similarly, we have got here non-scarring alopecia, right? What is this? Alopecia. Alopecia is simply thinning of hair, right? Thinning of hairs, body hairs, right? Okay, there will be thinning of hairs. Now similarly, we have got what? Oral or nasal ulcers. Now what are these oral and nasal ulcers? These oral and nasal ulcers, right? See, if I mean in daily life the ulcers are so painful, but here the ulcers that we find in this condition in SLEs have a characteristic feature that they are what? They are painless. They are painless. Okay, talking about the joint disease, right? Talking about the joint disease, here the joint disease, right, involved will be 2 or more peripheral joints, right? There will be the involvement of 2 or more peripheral joints in which damage to articular cartilage is not seen. That means non-erosive. Okay, what I said is non-erosive. Damage to carticular cartilage, non-erosive, right? No damage to what I said, articular cartilage. Okay, similarly, now talking about serositis. What is serositis? Serositis is simply the inflammation of serous surface, right? Inflammation of serous surface. What are the serous surface? Pleura, right? We can see pleura, we can see pericardium, right? Pericardium. Okay, inflammation to these surfaces. This is serositosis. Similarly, there can be renal disorders. What are renal disorders? Right? Renal disorders in which we may find proteinuria. What I said is proteinuria. Proteinuria, proteinuria, and we can also see red cell casts, right? What I said is red cell cast. Similarly, there are several neurological disorders in which we can find what? Decrease in brain functions. We can find seizures or epilepsy. Talking about hemolytic anemia, right? There will be autoantibody against what? RBCs. What I said is RBCs, right? Now, and similarly, there can be autoantibodies against WBC, and that would cause the reduction of WBC less than 4,000 per mm cube, right? And similarly, autoantibodies against platelets, that will cause the condition such as there will be less than what? 1 lakhs per mm cube, and the condition is thrombocytopenia. And these were what? These were the clinical criteria for SLEs. Now, out of these all clinical criteria for SLE to be confirmed, we need how much? 4 clinical criteria. That means out of these 4 clinical criteria and 1 immunological criteria. This will suggest what? This will suggest that the patient is suffering from SLE. Now talking about immunological criteria, or we can say it as a laboratory criteria also. And here what we'll find is we'll find antinuclear antibody, right? ANA. There will be antinuclear antibody in blood in large amount. Similarly, anti double-stranded DNA antibody will be found. Similarly, anti-Smith antibody, right? Anti-Smith antibody, anti-phospholipid antibody. I have already said that we are going to talk about these things in detail, right? Don't worry, we are going to talk about these things in detail. Similarly, there will be low complement. I said, right? There will be low complement whenever we are going to be having presence of antigens against which antibody formation takes place, then they will activate complement system by classical pathway, right? By classical pathway. When you activate complement system by classical pathway, early complement protein are likely to be consumed, right? And what are the early complement proteins? C3 and C4. Okay, the thing that I said I would like to repeat it again. I said when we are going to be having the presence of antigen, right, against which antibody is forming, right? Antibody is forming, they will activate, and this thing will cause the activation of complement system. And here the complement system is activated through classical pathway, right? Classical pathway. And in classical pathway, if you remember, then there will be consumption of early complement proteins, which are C3 and C4, right? So in SLE we can find that there are less number of C3 and C4. Okay, and another thing is this reacts to Coombs test, right? Okay, simply what is Coombs test? The Coombs test is done, Coombs test is done, right, to detect autoantibody against RBC's antigen, right? Autoantibody against RBC's antigens, right? Okay, now the condition here what comes is, while testing while we are doing test for SLE, or where we are diagnosing for SLE, at that time if the person is suffering from autohemolytic anemia, then there will be a large number of autoantibodies, right? Autoantibodies against RBC antigen. So now we need to get ourselves clear that during testing, or during the time of test of diagnosis of SLE, there should not be what? There should not be presence of systemic hemolytic anemia, right? Okay, in the condition of systemic hemolytic anemia, there will be large number of antibody, but in the case of SLEs, there will be some number of antibody against RBC antigen, right? So we need to we need to be clear that we need to be clear that there won't be presence of hemolytic anemia, right? And these are, okay, what I said is there should be 4, right? They can be in any format. I mean, there should not be, it is not compulsory that they should be in what synchronized format. I mean, they can occur at the same time, or they can occur one after another, it doesn't matter, but there should be 4 clinical criteria and 1 immunological criteria to find what? To find out that the person is suffering from SLE. Now moving forward, right, now we will know about the several involvement, right, several involvement of different organ or system in our body. Talking about the several involvement, we would like to move toward the skin involvement. Talking about skin involvement, as you have seen here the diagram, this is what we will be talking about, but simply now let us talk about skin involvement. What I said is skin involvement. Okay, skin involvement. Talking about skin involvement, we have already discussed a bit about skin involvement, and the skin involvement here, there will be the appearance of butterfly rash, right? Butterfly rash. Now what is this butterfly rash? We have already said that from this breeze, right, breeze of 2 nasal cavity, there arises rash that will spread toward the malar region or the cheek region, and this right, and this will increase as there will be high exposure to UV radiation. That means increase in intensity on UV rays exposure. Now that is what the skin involvement tells about. Now here in skin involvement, you can see that here you can see that there will be a slight change in what? There will be a slight change in our epidermis and dermis, and also there will be something in between dermal and epidermal surface. Now what will happen here is, okay, I would like to read this out. Systemic lupus erythematosus involving the skin, right? It is a diagram of the patient suffering from systemic lupus erythematosus, and it is the skin of patient. Right here, what will happen is an HE stained section shows liquefied degeneration of basal layer of epidermis. Okay, now this is the epidermis, right? Here this is the epidermis. What is shown here is there will be liquefactive degeneration of basal layer. There will be liquefactive degeneration of basal layer in what? In epidermis, right? What I said is liquefactive degeneration of basal layer. Similarly, what will happen in dermis? Now let us see toward dermis, right? Epidermis and edema. Okay, edema at the dermo-epidermal junction, right? Edema will be there in the dermo-epidermal junction, And immunofluorescence micrograph stand for IgE rebel deposition of IgE along dermoepidermal junction, right? Okay, what it is saying is this is the immunofluorescent, right? This is the immunofluorescence. Now here what we can see is this is the region of what? This is the region of dermal epidermal junction, and here we will find a lot of deposition of antibodies. Now this is what we find in immunofluorescence. And now here another point that it was saying is in this dermal junction there will be the presence of what? Edema, right? Edema, right? There will be the presence of edema. Okay, now this was all about skin involvement. Now oral cavity involvement, while talking about oral cavity involvement, we have already said that okay, let me mention here what I said is oral cavity involvement. Talking about oral cavity involvement, what we found was there was painless ulcer, that we have already said that in other ulcers we find pain, but in this ulcer we don't find pain. Similarly, talking about the joint involvement, we have already discussed about joint involvement also. What we discussed in joint involvement is there will be involvement of two or more than two type of joints, peripheral joints, and what will happen there is there will be non-erosive what? Non-erosive arthritis. Okay, let me write non-erosive arthritis. Now what is this non-erosive arthritis? I have already mentioned that there won't be, right, there won't be erosion in articular cartilage. That is all about joint involvement. Now talking further, right, talking about further, what we mentioned till now is skin involvement, joint involvement, and we have got what? Oral cavity involvement. Now talking further we have pulmonary involvement. Now what about pulmonary involvement? Talking about pulmonary involvement, right, pulmonary involvement. Okay, talking about pulmonary involvement, the thing that we will find here is there will be pleuritis. Okay, pleuritis, right, and this is the most common pulmonary involvement that we find. Now another thing that we find is there will be weakening of diaphragm. That means diaphragm will be weakened, right? It will get weak. That means diaphragm, diaphragm weakened. Now as we know, this diaphragm, it is the most important muscle for inspiration. As it will get weakened, will the lungs be able to perform inspiration so well? Obviously not. What will happen? These weakened diaphragm will not allow lungs to what? This will not allow lungs to expand in its full extent, right? And when these lungs, they won't get expand to its full extent, what will happen is there will be the condition of shrinkage of lungs. What I said is these will eventually cause shrinkage of lungs, shrinkage, shrinkage of lungs, right? Shrinkage of lungs. So this is we can remember it like this, S and L, and this is where it is found. It is found in SLE, right? Two words, the front two letters, we can remember it like this. Okay, this was all about the pulmonary involvement. Now talking about kidney involvement or renal involvement, the next one we have got is renal involvement. Now talking about renal involvement, okay, before getting into this discussion, I would like to make you clear that WHO have categorized, depending upon the extent of injury in renal system or in kidney, the WHO have given different grade. The different grade are from 1 to 6. There are different grade to which we can classify the type of severity in injury, right? And the criteria that will fall in this SLE is this: it is type 4 glomerulonephritis, right? What I said is WHO has classified from 1 to 6, right, the criteria on which we can divide the severity of infection in kidney, right? And under that criteria we have the renal infection or the renal involvement or the severity of kidney which falls under SLE is type 4, right? What I said is type 4 glomerulonephritis. What I said is glomerulo, right, nephritis. Now what is this type 4 glomerulonephritis also called? It is also called diffused proliferative glomerulonephritis. What I said is diffused glomerulonephritis. Okay, now we can also remember it by just this 4, right? Let's highlight this 4, and as we have highlighted this 4, and let's highlight this D, right? D is the fourth letter of in English alphabet. So now we can memorize it like this. So now this diffuse glomerulonephritis or type 4 glomerulonephritis, it is the most common type, right? It is the most common type of glomerulonephritis out of all 6. And what we can see, one of the important characteristics that we see in SLE patient is we will see here wired loop lesions. What I said is wired loop lesions. Now what are these wired loop lesions? If we see blood vessels in glomerulus, okay, let us suppose these are the blood vessels in glomerulus, right? Glomerulus, these are the blood vessels in glomerulus. What will happen here is we will see deposition of immune complexes in peripheral part of these glomerulus. Okay, what we will find? We will find deposition, right? What we will find? We will find deposition, right? Like this. We will find deposition. We will find deposition on peripheral part of these blood vessels, the blood vessels of glomeruli, right? We will find it like this. Okay, these are, and what are these? These are the deposition of immune complexes, right? Okay, now this will give a structure, right? I mean this will be appeared as wire, right? It will be appeared as a wire while viewing, so it is given the name of wire loop lesions, right? Now similarly there is another term that we need to know, and the another term is full house phenomenon. What is the another thing? Is full house phenomenon. Now what is this full house phenomenon? What is this full house phenomenon? Now through immunofluorescence we found a lot of deposition of immune complexes, right? Such as what? We found a lot of immune complexes, not only immune, through what I said is, okay, what I said is through immunofluorescence we found a lot of deposition of immune complexes, and along with immune complexes we also found a lot of complement proteins, right? Complement proteins, the immune complexes like IgE, IgM, IgA, right? Similarly the part of light chains kappa and lambda, and these were also found in that depositions. And similarly along with these there we found a lot of complement proteins also. So since it contains a large number of things, it contains a large many things, right? So it is called as full house phenomenon, and that is the concept behind it. Now this was all about what? Renal involvement. Now I would like you to take toward cardiac involvement. And talking about what I am saying is we will be talking about cardiac involvement. Now talking about cardiac involvement, we will find here pericarditis, right? Inflammation in outer layer. What we will find is pericarditis. Okay, now this involvement of pericardium or pericarditis is the most common cardiac involvement found in SLEs. Now similarly, as we have talked about the outer layer, there will be also a infection in innermost layer and valves. Now what is that condition? That is endocarditis. Now here the endocarditis that we will be concerned about is Lehmann-Sachs endocarditis. What I said is Lehmann-Sachs endocarditis. Lehmann-Sachs, yes, is CKS, Sachs endocarditis. Now what is this, right? Here what will happen is in this Lehmann-Sachs endocarditis, what will happen is there will be deposition of vegetations, right? Now what are these vegetations? These vegetations here are simply the antibodies depositions, right? The antibodies deposition. Okay. Now where these vegetations or deposition of antibody will take place is, they will take place on the lower surface, right, lower surface of mitral valve. Okay, let us suppose this is our what, this is our mitral valve, right, and this is the lower surface. As you can see, in lower surface I have drawn a lot of what, I've drawn a lot of vegetations, but there are also a vegetations on upper surface, but comparatively the lower surface contains what, a lot of vegetations. Okay, now it is simple. Okay, here also we have got one simple trick how we can memorize it. This is L and L, that means Liebman sac endocarditis, where there will be vegetations on lower surface of mitral valve, right? And similarly this Liebman sac endocarditis is found in SLE. We also can remember it through simply what trick, SLE, and this is LSE. This is what, LSE. What we are doing here is we are just changing the place of S and L, right? And we can know, simply we can memorize it like this. Okay, this was about the what, about cardiac involvement. And if you see here, these that you are seeing here are, these are what, these are the vegetations, right? These are the vegetations. And this is what, this is mitral valve. And let us read this here. What it writes is Liebman sac endocarditis of mitral valve, okay, in lupus erythematosus. The vegetation attached to margin of thickened valve leaflet are indicated by arrows. Okay, we have seen it here, right? Okay, that's all, nothing more here, right? This is what, Liebman sac endocarditis, and it is in what, it is in mitral valve, right? The vegetation here are shown with this arrow mark, and we have already known about it. Okay, now this was all about what, this was all about our what, cardiac involvement. Now let us be on another involvement, and another involvement is splenic involvement. What I said is spleen involvement. Okay, before getting into spleen involvement, I would like to recall the discussion, right? That spleen contains of what type of artery? It contains penicillary artery, right? What spleen contain is, it contain penicillary artery. Now this penicillary artery, right, this is the penicillary artery. Let us suppose this is the penicillary artery, right? These penicillary artery are surrounded by deposition of several what, immunological complexes, and when these complexes are deposited around the penicillary artery, there appears, right, the onion skin like appearance. Now what is this? This is onion skin appearance, right? This is what, this is onion skin appearance, right? Okay, now what we can say is the onion skin appearance in blood vessels are seen, right? And what are these deposition? These deposition are the deposition of immune complexes, right? Okay, that's all about splenic involvement. Now the most important one that we need to know is, okay, I'll write it here. The most important one is blood involvement, right? Blood involvement. Talking about blood involvement, there will be production of a lot of autoantibodies. Now what are the autoantibodies? Now talking about autoantibodies, there will be what, the first one that is the most important, what is anti-nuclear antibodies. What I said is anti-nuclear antibodies. Now what are these anti-nuclear antibodies? Okay, now let us say that this is the anti-nuclear antibody is the most sensitive test for the diagnosis of SLE. What I said is the most sensitive test, right? I said the most sensitive test. I did not say the most specific test, because this is also present in other autoimmune disorders. So it is the most sensitive test. Now moving into another point, and another point is what we have got here is we have got anti-Smith antibodies. What? Anti-Smith antibody, right? Similarly we have got another, and that is anti-double stranded antibodies. Okay, anti-double stranded, right, DNA antibody. Now these two are most specific for diagnosis of what? SLE. Now I'm going to write these are what? Most specific, right? Specific test. That means they will diagnose, the presence of these antibodies in individual will help us to diagnose that there is the presence of SLE. Similarly, the other antibody that I'm going to talk about is anti-RO antibody. What I said is anti-RO antibody, right? Okay. Now along with it, I'm going to mention about another one. Okay, and the another one is anti-B2 glycoprotein antibody. What? Anti-B2 glycoprotein antibody. Now, why I wrote these two together? I wrote these two together because, right? Because if patient is having SLE, right? If patient is having SLE and that patient is pregnant, right? And that patient gets pregnant. Now, the thing that we need to search in that patient is we need to search this anti-Rho antibody and anti-B2 glycoprotein antibody. Why we need to search that? Because these antibody in pregnant women causes what? These causes not these. This one causes what? Neonatal lupus. What they cause is neonatal lupus. Now what is this neonatal lupus? This neonatal lupus is simply systemic lupus in fetus or in baby. That's all, right? Now one a bit dangerous thing that can happen here is there will be a high risk for congenital heart block. What I said is high risk for congenital heart block. Okay, now what we need to remember here is, what are the things that we should keep in our mind is these the pregnant woman, what we will find in her body is, we will find what? If she is suffering from SLE and she is pregnant, then we will find anti-RO antibody. And what this anti-RO antibody does is it will cause what? Neonatal lupus, right? Systemic lupus in children, right? In baby or in fetus. Now and another important thing that we need to know is this neonatal lupus can be followed by what? The increase in risk for congenital heart block. So at this time there will be a very scary condition, right? Okay, now talking about anti-B2 glycoprotein antibody. Now talking about anti-B2 glycoprotein antibody, the thing that we need to know is it is what? Anti-phospholipid antibodies, right? Glycoprotein are what? These are the phospholipid, right? We can write it that these are what? These are anti-phospholipid antibodies, right? And if you will concentrate on the words APLA, OPLA, what I said is APLA, OPLA, right? These are what? OPLA, right? Anti-phospholipid antibodies, right? Okay, now these I wrote here OPLA because these anti-B2 glycoprotein or anti-phospholipid antibodies are responsible for OPLA syndrome. Now what is this OPLA syndrome? OPLA syndrome. Now the thing that we need to be clear here is this glycoprotein are what? These glycoprotein are phospholipid, right? These glycolipid are phospholipid. Now where are these phospholipid or the glycoprotein present? These glycoprotein or phospholipid are present on where? On the surface of, right? On surface of endothelial cells. Similarly on monocytes. On what? On, we can say these are also present in platelets, right? Similarly they are present in placental surfaces. Okay, these glycoprotein are present in what? These are present in endothelial cells, monocytes, platelets, placental surfaces. When there will be the formation of antibody against these glycoprotein, then obviously these structure will get damaged or they will get destructed, right? And when this placental surface will get disturbed, then obviously there will be the chance that that mother will have what? That mother will have abortion. And here the abortion will repeat again and again, right? So one of the clinical manifestation that I would like to mention here is there will be, what will be there? Present of recurrent abortion. What I said is present of recurrent what? Present of recurrent abortion. Okay, now since not only placenta, these endothelial cells will also get damaged, right? Since these endothelial cells will get damaged, there will be what? There will be clot formation, right? As there will be clot formation, there will be a high chance of thrombus formation. So one of the important point that we need to mention here is induce prothrombotic state. What I said is induce prothrombotic state. Now here what comes here? That means what comes here is predisposed to what? DVT. What will happen here? Deep vein thrombosis. Similarly the other are HVT, right? Hepatic vein thrombosis, that could eventually lead to stroke. Now this was about endothelial cells damage, right? Now talking about another thing is, right, these anti-beta 2 glycoprotein antibodies, they also cause increase in APTT, right? What I said is they also cause increase in APTT. Now what is this APTT, right? Okay, now what happens here is these autoantibody interferes, right? The autoantibodies produced will interfere with what? They will interfere with intrinsic pathway of coagulation cascade, right? Now as it will interfere with the intrinsic pathway of coagulation cascade, there will be increase in APTT, right? Prothrombin time. Okay, now this was about this thing, right? Okay, now another thing that we need to know here is as we are talking about what? We are talking about anti-B2 glycoprotein antibody. These are seen especially in female, right, in reproductive age group. We are already talking about the pregnancy's condition, right? Another antibody that I would like to mention here is anti-P antibody. Now what is this anti-P antibody? Anti-P antibody, right? These anti-B antibody are used in diagnosis of psychosis, and that is what we need to know. These are used in diagnosis of psychosis. Okay, this was about the blood involvement, right? The blood involvement, the several antibodies that we will find in blood. Now proceeding forward, the thing that we need to know is, right, okay, now the thing that we need to know is there is one important cell, right? There is one important cell, and the name of cell is LE cell, right? Okay, this is important concept and also interesting topic, LE cell. Now what are these LE cells? Now talking about these LE cells, okay, we need to know is patient having anti-nuclear antibodies, right? What I'm saying is patient having anti-nuclear antibodies, ANA, right? They will damage or denaturate the nuclear chromatin inside the cell, right? Inside the nucleus, they will damage the nuclear chromatin inside the nucleus, right? Now these damaged or denatured nuclear chromatin are called LE bodies. What I'm saying is there is ANA. What is this ANA? Anti-nuclear antibody. What they will cause is they will cause denaturation of nuclear chromatin. What I'm writing is nuclear chromatin, right? Okay, now denaturation of nuclear chromatin or damaged nuclear chromatin are called what? These are called LE bodies. Now look the relation. Now these LE bodies, they are phagocyted by what? Neutrophil and macrophages. as they will be phagocytized by phagocytic cells, now these neutrophils and macrophages, they will be called as LE cell. So the presence of LE cell is also a feature of SLE, right? Okay, now while talking about these LE cells, I would like to mention another cell, and we should never confuse between LE cell and TART cell. Now what is this TART cell, right? TART cell. Talking about TART cells, these TART cells, right? These TART cells okay, now here these LE cells, what these LE cells were having is these LE cells were having denatured nuclear chromatin. These were having the nuclear chromatin that were denatured, right? That were destructed. But these TART cells are same like LE cells, but here what they will have is they will have intact nuclear chromatin, right? Intact nuclear chromatin, right? Okay, TART cell are also what the phagocytic cells, neutrophils and macrophages, but what happens here is instead of denatured or destructed nuclear chromatin, the thing that is present within TART cell is intact nuclear chromatin, right? Intact nuclear chromatin, and that is the important thing that we need to know. Okay, when mentioning about these things, I would like you to take you toward another term, and another term is imperipolesis. What I'm talking about is imperipolesis. Now what is this imperipolesis, right? Okay, imperipolesis, what is this imperipolesis, right? The cell, right, there is one cell, and this cell contains another cell within it in intact form, in living form. Okay, this means cell within cell in what? In intact form. Okay, then what is phagocytosis? I mean, how it is different from phagocytosis? Okay, talking about phagocytosis, what is phagocytosis? In phagocytosis also, what happens is WBC is one cell, and this WBC is, right, engulfing microorganism, and obviously microorganism is another cell, right? The similar condition to imperipolesis. But what happens here is this WBC, which is engulfing microorganism, the lysosome of this WBC will destroy that microorganism and will not allow that organism to live within WBC. That means in phagocytosis there is dead cell within cell, right? What we can say is here there will be dead cell within cell. We can say, okay, we can write that, right? Dead cell within cell, right? Okay, that is how the imperipolesis and phagocytosis differ from each other. Now talking about imperipolesis, this imperipolesis, it is found in Rosai-Dorfman disease. What I said is Rosai-Dorfman disease, right? It is found in Rosai-Dorfman disease, and other condition in which we find imperipolesis are AML, CML, Hodgkin's lymphoma, right? Okay, these are the things that we find here. Now as we have talked about what we have talked about LE cells, right? Now the thing that we need to know is how we will treat these SLEs, right? How we will treat them. The main since it is the disorder of immune system, the thing that we need to provide to patient is steroids, right? The treatment procedure are steroids. Steroids are the choice of drugs for treatment of SLEs, right? Now we're talking about treatment. I would like to take you toward the drug induced lupus. What are the drug induced lupus? Drugs induced lupus. Now the drug induced lupus, that means the drugs. Now here what will happen is there will be history of intake of certain drug by patient, and this intake of certain drug of patient will enhance SLEs or will cause SLEs, right? Drug induced lupus. Now here the drugs responsible for inducing lupus are, we have already talked about these drugs, and these drugs are what? SHIP. This is the acronym SHIP, right? And these are also called offending drugs. What I said is offending drugs. Okay, from S we have got what? We have got sulfonamides, right? Dapsones, right? Sulfonamide. Similarly, from H we have got hydralazines. From I we have got isoniazid, right? From P we have got procainamide, right? These are also called what? Offending drug, right? SIB drugs, right? Okay, now here drug induced lupus, right? Drug induced lupus, there is involvement of various system in body, but there won't be involvement of what? There won't be involvement of kidney and brain. No kidney and brain involvement. Suppose we have got patient, right? We have got patient, and that patient is having a lot of characteristics, feature of SLEs, right? And among that characteristics we don't find the involvement of kidney and brain, such as we do not find type 4 glomerulonephritis, right? We do not find that, right? If we don't find that, and we don't find what? Seizures, right? Delayed brain activities, right? If we don't find that, then we will come to the conclusion that this SLE is caused because of drug induced, right? Because of intake of these drugs, one of these drugs. Now that is what it is, right? Okay, now how we will treat the patient who are suffering from this drug induced lupus, right? We will treat them by withdrawing these drugs, right? These drugs, the sulfonamide, hydralazine, isoniazid and procainamide, will withdraw this drug, and after withdrawing or discontinuing this drug, the patient will be treated. Now this was all about what? This was all about our lupus erythematosus, right? This was all about lupus erythematosus.